everyone, so we are learning about fungal infections, and what we are going to study now, it is Mycetoma, or another name is Madura foot. It is also called as Madura mycosis. So first of all, we will say about the clinical presentation of the patient. So the patient will be having, first of all, the patient will be having a history of thorn prick. So in that area later painless nodules will develop, and then it will be forming sinuses. Now from these sinuses there will be discharge, and the entire feet will get swollen up. So this is the clinical presentation of the patient. So that is a presentation of Mycetoma or Madura foot or Madura mycosis. So initially I told that there will be a history of thorn prick. In that area they will develop as a nodule. Now that nodule later that will break, and what happens, it will form as a sinus. But you should remember that the nodule will be painless. There will be no pain. So remember that it is painless. Now after that, from the sinus that will start to discharge certain grains, and later the whole foot will become hard and swollen, just like what you see in this picture, but still there will be no pain. So this I am representing some grains from this, discharge grains. So you can see in this picture the sinuses. So from the sinus and all there will be grains, and the entire foot has swollen up. So this is actually a triad of sinus, discharge, that means grains, and the tumefaction or swelling. Now you have to remember that, so we know this is the epidermis and this is the dermis. Now after that you have the subcutaneous tissue, then after that you have the bone. So in this Mycetoma, the areas getting affected, it will be the dermis. Dermis will get affected, and also the subcutaneous tissue can destruction can occur, and even the underlying bone can also destroy, like it can cause infection at last. Osteomyelitis or periosteitis can also occur. And very important to remember, there is no involvement of lymphatics. So that is how it is differentiating from sporotrichosis. In that also there will be a history of thorn prick, but the presentation is entirely different. Here we have told about the triad of grains, swelling or tumefaction, and also we told about sinus. So this is the triad which we observe in Mycetoma, but you cannot see this in sporotrichosis. So in sporotrichosis there is lymphatics involvement, but here there is no lymphatic involvement. So these are important to remember. Now the question is, this triad, you can see the swollen foot with a discharging sinus in other presentations also. So here you can see the presentation of swollen foot with a discharging sinus. So which are the conditions? You can see this. We have told about this Mycetoma. So Mycetoma is actually caused by which organisms are causing Mycetoma? It can be a bacteria or it can be a fungus. So the filamentous bacteria or a true fungus. Filamentous bacteria or a true fungus. So the filamentous bacteria is Actinomycetoma and the true fungus it is Mycetoma. Both are actually saprophytes in the soil. Now, how can we know by a clinical presentation whether it is Actinomycetoma or Mycetoma? By looking at the grains. So, if the grains are dark colored, then it is Mycetoma. So, in Mycetoma, the grains are dark colored, whereas in Actinomycetoma, the grains are white or pale colored. So the organisms in Mycetoma includes Madurella species, whereas in Actinomycetoma the species you can remember as NASA, NASA. So first N is for Nocardia, then it is Actinomadura and Streptomyces. And last A is for Actinomycetoma. So Nocardia, Actinomadura and Streptomyces, these are the organisms causing Actinomycetoma, and Madurella species cause Mycetoma. So you can remember the word mad. That means this is Madurella species will cause dark grains. You can remember like that. So we have said that if you are getting a history of thorn prick and also the swollen foot with discharging sinus, you can think of this Mycetoma. You can think of this filamentous bacteria, that is Actinomycetoma, and also you can think about entry of Staphylococcus. So that is also a differential diagnosis, Staphylococcus, which is causing Botryomycosis. You should remember this also at that time, Botryomycosis. So for a differential diagnosis of a swollen foot with a discharging sinus and also a history of thorn prick, you should think about staph, that is Botryomycosis, and entry of fungus, which is a fungus causing Mycetoma, and also the filamentous bacteria, that is Actinomycetoma. So that is a differential diagnosis. You have to think about three cases. In all the three you get this same, almost similar presentation. Now how can you confirm? So you can do a skin biopsy. That is the best method. Now if you do a skin biopsy, what you observe is in the center you can see the grains. In the center of this inflammatory response, and there will be abscess also, whereas when you look at the periphery you can see club formation. So that is the important one, that is skin biopsy is the best method. In the center of the inflammatory response you get grains, while club formation in the periphery of a grain is seen. And also you can see the abscess. Now another thing you can do is, so this is actually the picture of the grains. So here the grains are black in color, that means it is Mycetoma. So you remember MAD, Madurella species cause dark grains. So this is another technique you can do investigation, that is KOH smear. From the grains you do a KOH smear. So you can see. And how can you identify fungal grains or actinomycotic grains? From the appearance you can observe by looking at the color. Now from the KOH smear, the fungal grains will be looking broader. And if it is actinomycotic, we know it is a filamentous bacteria, so you can see fine filament. Now at last you can do an MRI. In the MRI you can see this picture. There is a dot in a circle. You can see there is a dot, surrounding that there is a circle. So it is actually corresponding to the grains in the sinus. So you can see all this dot in the circle. So that you can do a radiography. MRI can also be done. Now let's study about the treatment. So treatment is different for both. So it is important to know which one is this mycetoma, that is actinomycotic, or it is Mycetoma. First of all, you have to identify by all these investigations. And if it is Mycetoma, what you can do it is itraconazole. Whereas in actinomycotic mycetoma, there is a regimen called a Welsh regimen. Welsh regimen is actually amikacin and cotrimoxazole. And another, now we have also added rifampicin to it. So now it is a modified Welsh regimen, that is we have amikacin, cotrimoxazole and also rifampicin. So you should remember this Welsh regimen, and itraconazole is for Mycetoma. Then you remember dot in a circle sign and the KOH smear. Skin biopsy is the best method. And what are the differential diagnosis of this clinical presentation? It can be staph, botryomycosis, or it can be a fungus, Mycetoma, or it can be a filamentous bacteria, Actinomycetoma.